Hello, everyone. I'm Maria Theodoulou. I am a breast medical oncologist at New York Oncology Hematology. I'm the program director of the breast medicine division. And this is going to be another chapter in our patient educational forum. Tonight, we're going to focus on bone health and how it impacts the general population as well as patients with breast cancer. I am pleased, honored, and humbled that I have with me tonight Dr. Azeez Farooki, who is an attending physician at Memorial Sloan Kettering Cancer Center, as well as an associate professor at Cornell Weill. He's an endocrinologist. His clinical interests and clinical research is well known, well published, multiple chapters. He has been at the forefront of bone health nationally for actually several decades. And so tonight we're going to explore what it means to everyone as we age from year to year, what it means to our bony skeleton, what things can make us more fragile, what we can do to protect it. So, hello, Dr. Farooki.
Hi, Dr. Theodoulou. And by the way, I'll make up a new word. The humblement is all mine, actually.
Oh,
You're
wow. Well, it's so nice
you're
to
the
be
rock
with you
star.
tonight.
Hey,
There are so many questions that I'm going to bring to you on behalf of the audience that's going to be looking at this program. And I think what I'm going to start off with is could you just tell us what is osteoporosis? What is it?
yeah, for sure. Osteoporosis, you can call it a disease that makes your skeleton thin and fragile. So normally, your skeleton is like a web-like architecture with lots of connections. And when one gets osteoporosis, these connections, these bridges that give the bone strength, struts they can be called, can deteriorate and drop out. So your bone quality is measured in that sense as bone architecture, and your bone density is the mineral in the bone. So the bottom line is that your bones become more fragile as a result of both loss of that mineral and loss of the bone architecture. And that predisposes you to getting broken bones. Basically, that's in simple terms. That's what it is. And it's not that it's like arthritis, right? Can be one knee, or you can have localized problems. But this is a diffuse, or as we say in medicine, right, systemic throughout the whole skeleton kind of issue with the bones getting thin. The tricky thing, we measure it at only the spine and the hip, and this bone, the forearm, the radius. So that's just the way it worked out. That those are the sites that we have the we can say that those low bone density at those sites predicts fracture.
At what
I can
point in
yeah.
time, at what age do we start to think about this or evaluate ourselves or have ourselves evaluated for bone health?
Yeah, excellent question. The standard, right now, in somebody without other risk factors and special circumstances, such as breast cancer, the standard would be 65 years in women and 70 years in men. But you can certainly justify screening because that's what this is. It's a screening test to see whose bone density is low and who's at risk for getting these fractures. You can justify it if somebody's in circumstances like they have breast cancer and they had an early menopause, they have breast cancer and they're on aromatase inhibitor therapy, these kind, or if it's a man, somebody who's on prostate cancer and is on androgen deprivation therapy that's making their testosterone go down to zero. So a whole multitude of risk factors and situations where you could justify it before then. If somebody's getting lots of fractures for no reason, you know, they should get a bone density. They should see somebody who deals with bone fragility. I mean, endocrinologists are one of those people.
Right, because there are other factors that could contribute to bone loss, like hyperparathyroid disease. And
Hmm.
sometimes we don't think about that, and we really should, especially in someone who sustains a fragile fracture at an early age.
Yeah, yeah, no, most definitely. I mean, I saw somebody today who had no cancer history, but had history of ulcerative colitis as a kid, and he was sort of in remission, but he also had asthma as a kid, and he took a lot of steroids, and so, you know, we wound up checking his bone density, and lo and behold, he was about 62. He had osteoporosis at the hip. So yeah, a lot of contributing possible factors that can affect our bone integrity.
So when we talk about bone loss, we're talking about bone resorption, we're talking about bone formation. What does that mean? How does that play out
Hmm.
when we're looking at this particular health issue?
Yeah, so I think it's important to have a sense of that. That's a good question. So you have cells in the bone that take out the old bone, and those are called osteoclasts. And then
Mhm.
you have that's like the demolition crew, and the repair crew comes in, and this is happening constantly in your skeleton, such that over 10 years your entire skeleton gets remodeled. So this process of the demolition crew and the repair crew um, is should be a net, neutral situation where you're not losing bone in the process. But in certain situations, certainly that can happen. Like, for example, steroid therapy, corticosteroid therapy for a lot of conditions, in fact, chemo as well. Sometimes we give high dose steroids. Um, that turns down the formation crew, the osteoblast cells from their activity, and it will increase the resorption activity. So that's definitely a bad actor on the bone. So many medicines like aromatase inhibitors are, even going through menopause. There's osteoclast cells become overactive, and so the demolition crew is going overtime. The repair crew can't quite fill in the holes in the bone. So we think about those processes, and the medicines that we have exploit, trying to put that process back in balance. Oh, and actually, so that a lot of the medicines, what they do is they turn down the demolition crew's activity, say, "Calm down, guys," and the repair crew fills in the holes in the bone, and so you gain some more mineral and integrity and strength in the bone.
So are you saying that some of these processes could be reversible?
Yeah, yeah, I think that when you think about the cellular activity, definitely you can reverse this overactivity of the demolition crew. You can exploit that. And, in the process, when you do that, also, I'll add one more thing. Remember, we were talking about these struts, these connections, that if you can imagine, if you have an overactive uh, pit resorption pit where it's not being filled up, then it'll drop out. If you stop that overactivity in the resorption, the Pac-Man like cells, they won't drop out. So you can maintain your architecture with some of these medications.
Can
So
we
yeah,
talk
you.
a little bit about these medications? Because there are so many different classifications. I know in my evolution of practicing close to 4 decades, um, I'm now unfamiliar with some of the newer medications that are out there. Maybe help us understand which medications are anti-resorptive, which medications are metabolic medications. Please.
Yeah, sure. So, the main two classes we have, there's a anti-resorptive, which, you know, fancy name, but it's lowering the activity of those Pac-Man-like cells, the osteoclasts, that the demolition crew, if you will. And, it so happens that when you do that, usually the bone formation goes down too. But in the end of the day, by lowering the whole process, it gives the forming cells, the repair crew, a little time to fill in the holes in the bone. Um, so anyway, that's one major class, the anti-resorptives, and within there's different players. And just the other major class is the anabolic drugs, and there are three FDA-approved anabolic drugs. Two of those are once a day injections that with a pen, device that the patient gives himself. Sounds bad, sounds like a pain, but it doesn't hurt to give the darn injection, thankfully. Um, you know, um, it's not walk in the park necessarily because it's, you got to give yourself an injection every day. But um, those two drugs, one of them is now generic or biosimilar, as we say. That's called Forte, used to be called Forteo. The generic name is teriparatide, and the other one is called Timlos, which is still not generic. Um, then the third player in that anabolic category is something called Evenity, which is probably the most potent bone building drug that really makes the bone density go up quite a bit. And that one is very interesting because if we go back to the demolition crew and the repair crew analogy, what it does is it turns on the repair crew like crazy to start with, and then it has lowers the activity of the demolition crew. So the best of both worlds. You're getting the repair crew turned on and the demolition crew turned down. The other drugs all don't have that ideal mix because, or they have a window of time where they work and so forth.
And this avidity, is it given indefinitely or is it continually building up bone?
No, it for 12 months is the FDA approved. Once a month, you come into the doctor and they give you a shot for 12 doses. And that's the status of it right now. So technically, you don't get repeated cycles, although I think studies are underway to see if that, would be feasible to, give a break and then give more of it, perhaps.
Well, the question that the patients are going to ask, and certainly my patients are, what about side effects?
Yeah, exactly. I knew that question was on our
You
mind. Yeah,
knew it, right?
honestly, there's no drug without side effects. That's absolutely true. The thing I would tell everybody that's listening is that you have to be cautious because when you do a clinical trial, and Dr. Theodula knows very well, you have to report all these adverse effects. And really, the question is it different in the placebo patients and is it different than the drug group? So if the placebo group has 5.2% backache and the drug group has 5.1% backache, well, backache gets listed as a side effect, right? But it's not necessarily any different, than the drug's not causing that problem, but it's listed, um, so, interpret it with the help of your doctor with any drug, what's a legitimate, scientifically real side effect from not. So with Evenity, in one of their three big studies, when they compared it to an older osteoporosis drug, used to be called Fosamax, there was a higher number of cardiovascular events, which is concerning. So heart attack and stroke and things like that. So what the FDA said is that if anybody's very high risk, like if they have in the last year a history of these events, you should not give them this drug.
Mhm.
So the other two studies with Evenity that compared the drug to placebo showed no imbalance. Interestingly, no increase in those events.
And were the
So
numbers on these three trials equivalent?
yeah, that's a good question. The study that showed the imbalance was a little bit more than the other two. But if you pool the other two, you're going to get a similar number. So the study that had the imbalance, it was 0.8% in the Evenity group versus 0.3% in the placebo group.
Mhm.
So that's turned out to be statistically meaningful, actually.
Yeah,
And so I take it seriously, and if somebody's an active smoker, their blood pressure is terribly out of control, their cholesterol is terrible, I'm thinking in my head that it's probably not the drug for this
right,
particular
right.
person.
So is it does it make a difference if one identifies bone density loss early on and treats it, or does it matter if they identify it later on in life in their 70s or late 70s or 80 and then decide to treat it? Do they have the same kind of reversibility?
You know, um, Probably it's better to pick it up early because you
Mhm.
can act on it and do things, whether it's even lifestyle measures, to try to reverse it. And even if we go early enough, there's a rapid phase of bone loss that happens right after menopause for women for about 5 years, let's say.
Mhm.
And, you know, that it brings up the question, which is a legitimate, question, is that, well, why don't we screen earlier? And if somebody's mom broke
That
their
was
hip,
going to be my next question.
yeah, yeah. I mean, if somebody's mom broke their hip, or if they have themselves had fractures, yeah, I mean that put, or multitude of things, right? If they had a history of, like we said, at that guy, of steroids and so forth. Um, Rheumatoid arthritis, there's a multitude of things, smoking, alcohol abuse, stuff. So it would make sense to screen earlier and kind of block that rapid bone loss that's going to happen at menopause. That would make sense to me, yeah, to kind of get on top. Yeah, I
I
mean,
think that that makes so much sense. And I do screen my patients at about the age of 50. I do start, especially because, my patients are patients that I might worsen that bone density loss because of therapeutic measures that we move forward with. I know that one of the issues is patients who are going to go on anti-estrogen therapy when they have hormone receptor positive breast cancer. And one of the common recommendations that we make, and for good reason, because of disease-free survival benefits and overall survival benefits, is an aromatase inhibitor, which you mentioned earlier. It's an interesting drug because its mechanism of action is very different than the traditional anti-estrogens that target the estrogen receptor. Aromatase inhibitors actually block estrogen being made from our steroids and our male androgens and so on. Um, at what point would we initiate um, bone health medications in a patient who has osteopenia? And let's, for the sake of this conversation, say that the T-score is minus 2.0 and
hmm
she's 52 years old, and it's in her hip and her lumbar spine. Just
yeah.
identified, about to start an AI.
Yeah, I tell you, I mean, in that type of patient, I mean, they don't have osteoporosis, right? Because the T-score is, that's minus
Mhm,
2.5.
mhm,
So for everybody listening, this minus 2 is osteopenia, and it's osteopenia is minus 1.1 to minus
mhm.
2.4. So the thing with this patient that would be concerning is that when you get on that aromatase inhibitor, you lose a lot of bone in the first 2, 3 years you take it. So, if we don't do anything, that there's a good chance that the patient could progress toward that osteoporosis number. Um, and we know that aromatase inhibitors, if you look at 5 years study from Austria, about 16, 17% of women got a fracture over that study duration. So that's untreated with any medicine, and we know that you can cut that risk by giving some medicine.
And
So,
then,
yeah,
of course, one of the questions is, do we know what their starting point was when they went on to the trial and were followed? Did
yeah,
the women
yeah,
have osteopenia already? Did they have normal bone
y-
density?
yeah. The really interesting thing about that trial was that you know, lots of those women, half of those women had normal or osteopenia. Actually, sorry, more than that. No, yeah, I believe it was like, half had osteopenia and 25%, let's say, had osteoporosis, and 25% had osteopenia. So it was a lot of women with pretty good bone density in that trial, and they were still getting fractures.
Mhm.
So it's that's concerning. I mean, that trial, with the caveat, there was a caveat here that those are all Austrian and Swedish women, and maybe their fracture risk is higher than different folks in the U.S. It's not entirely clear. Um, so that's still, though, I think that that patient, if they're within 5 years of menopause, wait, how old did we say they were again?
52.
52. Yeah. If
And
that
let's, for the sake of this, say that her last menses was at the age of 49,
hmm
3 years
hmm
ago.
Yeah. So she could still be in a phase of rapid bone
Mhm.
loss from the menopause. So I would have a very low threshold. I would, encourage that patient to be treated. And if they don't want to take a medicine, then you say, okay, well, let's recheck the bone density in 1 year and see what happened, because it could be that it's going to tank on us. And really, we're not that worried about them breaking bones left and right at a young age. But when they get older, the fracture risk increases just with age, as a direct result of getting older. So we want to preserve their skeleton for when they're older.
Well, Dr. Farooki, for the sake of argument, what about vitamin D? If that patient promises to be compliant with vitamin D intake,
Hmm.
is that really a real thing? Does it
Yeah,
help?
I do think it helps. I mean, I think that, over the years in the media, things have uh, gone back and forth a bit about the importance of it. And, the general population, there were recommendations put out that, um, don't go crazy checking for vitamin D, and 20, a level of 20 is adequate for the general population. Now, if somebody has osteopenia, osteoporosis, and is in a situation like this, yeah, I think it clearly is going to help, because direct effect on bone cells, as well as it helps regulate a hormone called parathyroid hormone, which, if the parathyroid hormone's too high, it's going to chip away at the bone slowly over time. Helps with absorption of calcium as well. If it really, you need a very low level to really get into that territory. Um, so yeah, I mean, the flip side of that is, don't think the more the merrier, because if you
Mhm.
start taking 10,000 units of vitamin D a day, it's bad for your bone. Your level is going to go too high. So we endocrinologists, and you guys check too, probably, I'm sure, the 25 hydroxy vitamin D level, and to make sure it's sort of in a sweet spot of, let's say 30 to 50 or 30 to 60. And, you get to the extremes, and it's really not good for you either way.
Right. And what about weight-bearing exercises?
Yeah, I mean, impact exercises are things like dancing, tennis, whatever you want, jumping, where you're putting impact on the bone, and that's been shown to be helpful. And the other thing is weight bearing, like pushing, putting a load on the bone, like if you're doing a recumbent leg press, and you're doing heavy weights. You kind of have to do heavy weights. You have to be a little bit of Arnold Schwarzenegger on this, and get a trainer maybe, and so forth. Um, Doing an exercise where you have to change direction, like pickleball, might be good too, because that the force that applies on the bone, there's some data on that as well, that's good to stimulate the bone cells in a favorable way.
So I've been telling patients for a long time, at the very least, walk uninterrupted for 30 minutes, 3 to 5 times a week. Have I
Yeah,
been telling them the wrong thing?
yeah, I like that. I would say uphill, downhill,
Mhm.
vary your route a little. Um, that's great standard advice for everybody. I mean, the more walking, the better, of course. If you want to do more than that, please go ahead. Um, for couch potato patients, there is a new thing, which is a belt kind of device. It's called OsteoBoost, that gives vibration targeted to the hip, both hips, and the spine. And the for years there was some vibration platforms out there that sort of, designed to mimic weight bearing and exercise, that by end of the day they didn't really pan out as being positive results. But this has been FDA approved, this OsteoBoost device, and based on a 1 year study, you know, bone density effects were modest, but they did a CAT scan and showed that the bone strength on this fancy technique called finite element analysis was improved, at the hip. So I like it, because I think it's not going to hurt. Um, the insurance isn't started paying for it. That's the one thing I would say about it, though.
That's wonderful. What
Yeah.
about supplements? Calcium, magnesium, B12, potassium.
Yeah, good question. So calcium, again, in the media, there's been some, oh, is it going to calcify my heart, and this and that. The final verdict on this is that in a patient with normal kidneys, it would not calcify your heart if you take too much calcium. But if you go crazy on the calcium, let's start from that angle, and you take too much, it comes out in the urine. So you can get a higher risk of kidney stones.
Hmm.
So what is the right amount is still, we think, is 1,200 milligrams a day from food plus pills. And so if you're getting, it's kind of hard to get 1,200 from food, but things are fortified. Oat milk, almond milk, I mean, regular milk has calcium. A lot of healthy foods have calcium. Um, so I still think it's worth scrutinizing that. Your multivitamin has calcium, Tums have calcium, a lot of things out there have it. Um, and seeing, the way we kind of fine tune it, if you go see an endocrinologist and you have osteoporosis, we might check a 24-hour urine collection for calcium and
Hmm.
sodium and creatinine. So that's the best way to tell if you're getting enough or too much, actually.
And when you're checking all of these blood tests and urine levels, and are you looking for bone turnover in some of these lab tests? And what does that
Yeah.
mean?
Yeah. So if we go back to the cells in the bone, those cells that take out the old bone, the demolition crew, we can measure their activity. And there's bone resorption markers, like there's one called beta crosslapse or beta CTX. It's an esoteric name for the amount of collagen that's being liberated in the bone resorption process. So if that's high, it means the demolition crew is going overtime and the repair crew can't keep up. And then what's high is a little debatable and so forth. But and then we have bone formation markers that we look at too, and oftentimes they correlate. But there's certain situations if your kidneys aren't working, there's one bone formation marker that's more reliable and so forth. Um, so we use these to monitor therapy in a lot, and see, because what happens is that if you have high bone breakdown, high bone resorption, and you take one of these anti-resorptive drugs, well, guess what? It goes down into a sort of premenopausal range, which is a healthier range for the bones to be at. So,
And what if you have a patient that has a very slow, low bone turnover? Is that a patient that can hold off on going medications?
it still, the data suggests that even if you have a low baseline bone turnover, you still benefit, you still get the anti-fracture benefit. This is looking at from the big trials of these medicines that were done years ago, and showing that even people with low bone turnover benefit. Um, so you might argue that, well, maybe that patient needs the other type of medicine, an anabolic medicine that turns on the bone formation and the bone remodeling.
Mhm.
Um, so that is a possibility, although in cancer patients, those anabolic drugs are not well studied. Um, I think we need more of that. In fact, we're doing one pilot trial in multiple myeloma patients with this same drug that we said, Evenity. Only 10 patients, but something.
So with your permission, and again for the audience and the questions that I get in clinic, could I call out some of these medications and you can tell us how they're administered, what patient population and what form they take, and how
Yeah.
long they should be treated? Is there a finite period? Do patients stop after 4 years? What happens after 4 years? So let's take a medication like Fosamax, alendronate,
Hmm.
which now can be given, it's no longer just a daily medication. Um, let's give a blurb on alendronate,
Yeah.
one of
Boy,
the old
alendronate,
ones.
yeah, oldie and goodie. I mean, I think that so alendronate is a bisphosphonate medicine, and it's an anti-resorptive, lowers the activity of the osteoclast cells, and the osteoblast cells cooperate because there's a coupling. So it sticks to the bone. Alendronate, when you take it for 3 years, 5 years, and then you were to stop it, there's a persistent effect because the structure of it binds to the crystals in the bone. And it the duration of it, oftentimes we think about a holiday, because why? Well, it has a persistent effect, and there are rare problems after, let's say, 5 years of continuous use. Uh, so those rare problems we think about in, very carefully, because if somebody's at high risk for fractures, there was a study with Fosmax or alendronate showing that if the patients stop after 5 years compared to those that stay on it for 10 years, there's significantly less spine fractures if you stay on it for 10 years. So these are painful clinical spine fractures. So let's say it's roughly 5% of the patients that stopped get it, and 2.5% of the patients that didn't stop get these painful spine fractures. So we weigh that against the side effects. The side effects in the osteoporosis world with that drug, the jawbone necrosis sounds scary, but it's so rare, it's almost not even worth thinking about because it's 1 in 10,000 to 1 in 100,000. And the other side effect is what's called an atypical femur fracture. And that's
Mhm.
a stress fracture that can happen in the thigh bone. And you say, what are you talking about? The drugs strengthen the bone. How can they do that? Well, exactly. It's a paradox that some patients, they're predisposed to the drug overdoing it and over suppressing the amount of bone remodeling, and there's a little stress damage that develops in the side of the thigh bone, and that can progress and become a big deal. So we tell people who have been on for 5 years or more that if you have pain in your thigh or your groin, let us know because that can be a sign that that's happening. But the risk of that is 1 in 5,000, more common Asian American women. So those are
It's
the
interesting because it was my patient at MSKCC with osteonecrosis of the jaw that brought this phenomena, to publication, as well as my patient with the femur fractures
wow.
that eventually led its way into the literature. And in both cases, I have to say, these patients were on um, anti-resorptive agents for a very long time because they had stage 4 breast cancer. We never
And they
stopped.
were
So some of these patients were on for 10 years, 12 years,
and they were
14 years.
getting
Yeah.
intensive doses, right? Like, for example, for probably were getting IV bisphosphonate like once a
Yes,
month, or
exactly.
yep. So like we give the IV bisphosphonate once a year for osteoporosis most
Mhm.
of the time. Yeah. So that's the thing. But one other word on the bisphosphonates, which you can also comment on, Maria, very well, is that there is this very interesting and important adjuvant effect, meaning less bone recurrence, that has been shown and accepted by pooling a lot of studies over the years together. The Europeans did this, and they conducted a meta-analysis, and they showed that this improves the survival of breast cancer, postmenopausal breast cancer patients, not premenopausal or perimenopausal, but postmenopausal breast cancer patients. And this benefit was there regardless of the estrogen receptor status. So even in ER negative patients, amazingly. Um, so that was shown with the IV bisphosphonate, zoledronic acid,
Right.
right? Every 6 months. Um, you probably only need to give it for 2.5, 3 years to achieve that adjuvant benefit. So I always, like to mention that to my patients because,
Mhm.
I think it's important.
It's powerful. It's powerfully important. Well, what about Prolia, denosumab, a rank ligand inhibitor?
hmm Yeah, so Prolia is a very effective drug for osteoporosis. Um, builds the bone density as good or better than the IV bisphosphonate, known as reclass. And the only thing with Prolia, it's complete opposite of sticking to the bone. If you stop it, let's say you take it for 3, 4 years, you gain a lot of bone, you stop it, and you don't chase it with a bisphosphonate. We say chase meaning just follow it. The sequencing of these drugs is important. The bone density tanks. It goes back
So there's
down.
no drug holiday with Prolia.
No, you have when you stop. If you were going to stop it, you better chase it and give a bisphosphonate to blunt the loss of bone density.
And what would
Uh,
be the time interval from that year 4 Prolia, and now we're going to move forward to transitioning to zoledronic acid, Zometa?
Well, the Prolia probably lasts about 6 months, right? So
Mhm.
you give that dose of zoledronic acid or any bisphosphonate, oral bisphosphonate, even 6 months after the final dose of Prolia, just about
Okay,
there.
great.
Yeah.
Um, One of the things that is always intriguing to me is the issue of estrogen deprivation, either from natural menopause or oftentimes um, we enact it in our patients surgically or medically. But in the general population, the non-breast cancer population, does our estrogenic environment when we're premenopausal really become disaffected once we or we have a natural ovarian suppression, our ovaries go to sleep? Um, is it has it been shown that if we take hormone replacement therapy that our bones will benefit?
Yeah, it's a great question. So, there was this study back in the day, as we say, the WHI study, and that stands for Women's Health Initiative. Huge study. And what happened as a result of that study, there were several risks of estrogen that were shown: increased risk of breast cancer, increased
Mhm.
risk of heart disease and stroke and blood clots in the legs. But there was a clear benefit in bone health. So there were less fractures in an unselected patient population. So normally, when you do an osteoporosis study, you take patients with low bone density who are at high risk. That was not the case in the WHI study, but there were less fractures in the patients that took the estrogen. So how do we reconcile the risk benefit with this? So it seems that for the heart health and so on, if you start the estrogen, see in the WHI study, they waited 10 years after menopause, generally speaking, to start the estrogen. But if you start it right at the time of menopause and you take it for 5 years, or some people would say take it for 10 years, um, that should not increase the risk of these problems in terms of the heart disease and so on and so forth. So breast cancer, I think that's still a bit of an open question, but um, you be screened for breast cancer these days, obviously, aggressively, and I think that would help.
Yeah, you said earlier that there's no medication without side effect, but there's no transition down a an aging pathway without potential risks. And I think if women and men are well versed and educated about what their bodies are beginning to encounter, how they can help potentially slow a process or reverse a process. I can't think of any other quality of life alteration than someone who's aging elegantly to sustain a hip fracture and wind up in a rehabilitation center and have their life altered. It really is uh, very, very sobering, I think, when we look at that and, who's in the nursing home, who's in a rehab center, when we know that if you look at worldwide, 90% of patients that are 90 years of age are living at home and well. Who are the ones that are winding up in a nursing home?
Yeah.
Um,
Yep.
I, there's no question that I think a thorough workup has to be performed when bone fragility is identified, looking at thyroid function, parathyroid function, medications that a patient is on, certainly looking at comorbidities. What is the initial workup that a primary care provider should be performing? What should a patient be expecting to be watched for?
Yeah. Um, I think that so the bone density, if they haven't had one, is a great screening test to see what's going on. But we do a whole panel that includes a phosphorus level, parathyroid, just like you said, thyroid. Alkaline phosphatase is something that comes as part of the comprehensive metabolic panel. It's called bicarbonate level because that tells us the acid base status. Because if somebody's too acidic for some reason, they could leach calcium out of the bone for that reason as
Mhm.
well. Um, yeah, vitamin D definitely important. So we look at a whole lot of things like that and try to see what secondary cause. I mean, if patient tells me, yeah, I got this like weird kind of GI issues and I have a rash and, I look for celiac
Mm.
sprue because that's another quote unquote secondary
Sure.
cause of
Mhm.
bone loss. Um, yeah, so there's a lot of stuff that can be teased out of it. I think primary docs, they usually around here, they refer to endocrinologists to try to figure out what else, we're missing here that could be contributing to this
I have to
problem.
say that I have beat up our endocrine friends up in this part of the world where I'm practicing.
Yeah,
I never take for granted that I can manage bone mineral density loss as well as the experts do, just like I don't expect my endocrinologist to manage breast cancer. So I think it's a
exactly.
lesson for all of us and really supporting programs to be able to develop, those subspecialties to be available to all of us, not just in tertiary centers, but in the community also.
Yeah, yeah, in rural areas, and absolutely, we need more. Even if it's not an endocrinologist, if it's a bone health, like for example at HSS, they have a fellowship that anybody, any
Right.
specialty can learn,
Right.
bone, metabolic bone.
Well, Dr. Farooki, I can't thank you enough for spending this time with me. The only thing that was missing is having a nice meal and maybe a glass of something together.
Yeah.
This is an important subject. I hope that the audience finds it helpful. I'm really excited about this series of programs that we're going to be putting forward, all of them really sponsored by a wonderful grant from Stacy and Richard Rosenthal. I need to give a shout out to them, to the New York Oncology Hematology Foundation. And we're going to be looking at so many different subjects. Everybody will be notified about when the series goes live for you to look at. And Dr. Farooki, what can I say? You have huge hugs and happy holidays from me. It's my honor, my pleasure, and I'm humbled to have your time tonight.
Well, you're so sweet, and hugs right back. Really, my pleasure. It was a great conversation. I think we covered a lot, and
We
yeah,
did, though, didn't we?